Okay, welcome everybody. I am Juliana, for those of you that I haven't met yet, and this is the voiceover for diabetes, the basics, and then we'll obviously talk more about it in class. Make sure you do your readings and look up your objectives and all that prior to lecture. So let's talk about diabetes. So what is diabetes? It's a chronic multi-system disease. Basically, right, we've got hyperglycemia related to abnormal insulin. It's the seventh leading cause of death in the United States. It's estimated that at least 1 to 2% of the population of North America has diabetes. It's the leading cause of adult blindness and stage renal disease and the lower limb amputations that aren't related to trauma. And it's a huge contributor to heart disease and stroke in Americans. So it's definitely a very significant condition that you're gonna see a lot of in your practice. So what happens in diabetes though, right? So what's our etiology, our pathophysiology? Well, your brain needs glucose for energy, and other parts of your body can consider alternative energy if there's not enough glucose, but the brain can't. So your brain's going to monitor your glucose level for survival, but you don't want too much glucose either because that could cause diuresis and dehydration through the osmosis of water from the body cells. So we have the islets of Langerhans in the pancreas. This is what regulates your blood glucose. And there's beta cells in there that are the source of insulin. And these beta cells are sensitive to those glucose levels in your blood. So they're going to secrete insulin when glucose is available. And beta cells increase the secretion of insulin. Also, glucagon is secreted by the alpha cells, which are also in the pancreas when blood glucose is depressed. And the effect of glucagon is opposite to insulin, but one of the major effects of insulin is on cellular glucose uptake. So in the liver, insulin has an important effect on glycogenesis. And so when you have enough glucose available, the higher insulin levels are going to promote the formation of glycogen as a means of storing glucose later for energy. But in diabetes, not so much the case, right? So diabetes is a major endocrine disorder. It's the most common endocrine disorder. And in insulin-dependent diabetes, basically what happens is it's an autoimmune destruction of the beta cells in those islets of Langerhans. And why that happens, we really don't know. But the result is that these altered beta cell antigens are recognized by the immune system as not being part of itself, and you've got that cell-mediated immune attack, and the beta cells are destroyed, and that's how we get these signs and symptoms that we recognize with diabetes. This can take a while to happen sometimes. So type 1 diabetes, we used to call this juvenile onset diabetes or insulin-dependent diabetes because we saw it mostly in children, develop in children. And that's still mainly the case, but now we call it type 1 and type 2. It's got an autoimmune component, genetic predisposition. You do have the latent autoimmune diabetes in adults, which is pretty rare and usually gets diagnosed as type 2 mistakenly. So with type 1 diabetes, what is going on here? Basically, the signs and symptoms we see in type 1 diabetes are due to the lack of insulin. Normally, insulin is 70 to 110, but when you have insulin-dependent diabetes, your glucose is going to be high, so hyperglycemia, usually over 180, but as high as 1200. And what happens is these patients start to lose glucose in their urine. The high level of glucose, because the glucose is just, it's not getting picked up. There's no insulin to grab it. The high levels of glucose in the urine are also going to increase the nephron tubules. It's going to increase that osmotic hold, and you don't get the normal reabsorption. So then you get polyuria. You get increase in thirst and water intake, which is polydipsia. You're getting depletion of body proteins because of the induced glycogenesis. because your protein from your muscles is converted to glucose lost in the urine. So the patient's going to experience weakness, fatigue, and weight loss. All right, and this is just something I put up there, a diagram you can take a look at later. A copy of these slides just by themselves without the voiceover is also posted on Blackboard for you. But you can kind of see the progression of type 1 diabetes there. So then we have type 2 diabetes. We used to call this adult onset diabetes or non-insulin dependent diabetes. But sadly, we do see type 2 developing in children sometimes because of the risk factors of obesity, etc. So we call it type 2 diabetes now. It's most common. 90 to 95% of all patients who have diabetes have type 2. What is interesting about this compared to type 1 is you do have some risk factors that you can modify, right? Obesity, physical inactivity, HDLs, triglycerides. These are all things that we can actually modify. We can change and decrease our risk of getting type 2 diabetes. Some things that are non-modifiable, of course, is if you're in a high-risk ethnic population, if you are a woman that delivered a baby over 9 pounds, these are some things that just put you at higher risk that you really can't do anything about. So what happens with type 2 diabetes, right? There's probably a genetic component in there a little bit, but there's a possible defect in the beta cell function. You do still get insulin secreted with type 2 diabetes, but it's not efficient. It's not being done well. The book calls it muted and sluggish. So basically then your glucose control is difficult. These patients a lot of times also have insulin resistance, meaning that the cells can't take up and metabolize insulin the way they should. So these patients experience hyperglycemia, even though they still secrete some insulin. Obesity is also a huge risk factor and plays a part in developing type 2 diabetes. We're not really sure 100% why. Might be that people who are obese have fewer insulin receptors. A combination of this with that genetic beta cell defect is going to result probably in non-insulin dependent diabetes. Also sedentary lifestyle, and they're thinking that's because of the lack of exercise means that the need for glucose in the cells is reduced and uptake is not normal. So with type 2 diabetes, sometimes diagnosis takes a while. It's kind of, you can have, a little bit of hyperglycemia without symptoms, and this could go on for a while. It's thought that the average person has had diabetes for over 6 years by the time they get diagnosed. And eventually these beta cells will undergo some, basically death and get replaced by fibrous tissue. This is different destruction than is experienced by the beta cells in type 1, but it's still happening, and the person with type 2 is still going to be experiencing the same clinical manifestations, that fatigue, poor wound healing, cardiovascular risk, visual disturbances, renal problems, and recurring infections. All right, this is just a little chart I threw up there in the slides that you can take a look at. When you look at the other slides, just kind of gives you some facts about diabetes. Then we also have prediabetes. So if you get diagnosed with prediabetes, it just means that you are at higher risk for developing type 2 diabetes in the near future. But it's kind of great. It's a wake-up call, giving you an opportunity to reduce the modifiable risks that you can, like obesity, activity, HDLs. It gives you that opportunity to fix those and try to make some changes in your lifestyle and prevent diabetes from progressing. So it just means that you really got to be careful because you're already having some difficulty with blood sugar management, although it hasn't actually progressed to diabetes. Then we also have gestational diabetes, and this is diabetes that occurs only during pregnancy. About 7% of pregnancies in the United States, this is happening. Usually It's definitely manageable, usually with diet. Sometimes pregnant women, if it's difficult for them to control their glucose, they have to go on insulin. Um, but you'll usually be testing your blood sugar, whatever the doctor tells the pregnant woman to do. High risk, if you're at high risk for this, they're going to test you early, but otherwise most women are tested between 24 and 28 weeks of gestation. And with gestational diabetes, most cases, as soon as the baby's born, just the diabetes disappears, but it does put the woman at risk for developing type 2 diabetes later on. So just so you can see the kind of the different clinical manifestations of type 1 and type 2 diabetes, some similarities, some differences, and just something that you need to be familiar with. And then you've also got the chart here to give you the comparison of type 1 and type 2 diabetes as well. And so how do we diagnose diabetes? It's basically going to be a combination of the symptoms with the blood draws to see what your blood sugar is. And they're looking at different levels in terms of a fasting blood glucose, anything higher than 126, 2-hour plasma glucose level of 200, or the classic symptoms with just a random glucose draw of 200 or more, or your hemoglobin A1C of 6.5% or higher. And hemoglobin A1C is a blood level that can be drawn that it gives you the more or less average of what your blood sugar control has been like over the past couple of months. So it's you can't cheat. So anything 6.5 or higher means that you are diabetic. It's just that you are not handling your blood glucose well. You're not controlling it. Here's another great chart. You can see, so we were just talking about hemoglobin A1C. Normal is less than 5.7. Pre-diabetes, 5.7 to 6.4. So remember I told you with that pre-diabetes, it's great. It's kind of like your wake-up call in order to, make some lifestyle changes. And 6.5 or higher renders you diabetic. All right, so when you're caring for your patient who is diabetic, right, what's our role? What are we going to do? And caring for diabetic patients is, especially newly diagnosed, is a multidisciplinary task. It's not going to be just the nurse. It's going to be the dietitian. It's going to be the doctor, because there's medications, right? There's dietary teaching. There's nurse teaching that needs to be done, and there might even be some psychosocial issues that the patient is struggling with, because this is it's a significant diagnosis and it's a lifestyle change. So it's important that we promote the well-being for our patients, help them with their symptoms, and teach them about their acute complications, and also help them to delay any onset or progression of the long-term complications. And here's just a great little chart that you can take a look at when you look at your slides later. And it just gives you kind of diabetes in a nutshell. Talks about complications, treatment, assessment, diagnosis. So you can take a look at that. All right. So diabetes, it's lifestyle changes, right? It's managed. It's a huge issue. This is not just like having the flu and getting over it. You're going to have to take care of this for the rest of your life in order to prevent the long-term complications from happening. Because those long-term complications are bad. We don't want them to happen. Patients are going to need to learn about self-monitoring. They may need some nutrition therapy. They may need guidance in terms of what they can do for exercise. Are there surgical interventions? When we're talking about surgical interventions, sometimes patients that undergo bariatric surgery end up curing their diabetes. So your book talks about that too. You can take a look at that. What's our nursing process in terms of diabetes? What are the developmental issues you need to be aware of with diabetes, right? Because if you, like we talked about the two different types of patients before, it's going to be significantly different for a young, teenager or young adult who's in college or working, or an athlete, if they get diagnosed with type 1 diabetes, rather than your 85-year-old little old man that is living in a nursing home and taken care of. These are going to be very different. There's going to be different issues, right, with this. You got to think of those developmental issues. What about children that are diagnosed, very young children? Sometimes they're 2, 3, 4 years old. And what are those developmental issues? And just helping your patient manage their diabetes. So self-monitoring, I'm sure most of you are familiar with this concept. This is a huge part of diabetes management, right? It's how patients make decisions on what to eat, how much insulin they should inject. They need to know their highs and lows. How often they test is going to depend on what their therapy goals are. What kind of patient are they? Like we said, the 22-year-old student athlete is going to be different than an elderly female with limited mobility. Under consideration when we talk about self-monitoring of blood glucose is what their goals are, what kind of what type of diabetes, type 1 or type 2, what are they taking as far as medication, or are they on insulin? Are they able to check their blood sugar? Do they want to take their blood sugar? Are they proactive, taking responsibility for their health? Do they have access to supplies and equipment? I'm sure most of you are familiar with the blood glucose monitors. We've used them in clinical. You may have a family member that uses one. You may have a job where you're testing your patient's blood sugar. So probably not an unfamiliar concept. There's also really, they're always developing new and better devices. Right now, I've probably seen the commercial on TV with the sensor, the one where it's a sensor inserted subcutaneously, and your glucose is displayed every few seconds. That's a continuous glucose monitoring system. So, they keep coming out with neat stuff, help people manage. So nutrition therapy is going to be a huge part of managing diabetes. Sometimes for type 2 diabetics, nutritional changes is all they need to control their blood sugar. We use, in my opinion, there's really no such thing as a diabetic diet. There is, it's a diabetic diet is a healthy meal plan that's really good for just about anybody. Diabetics need to be careful of things that have a lot of carbohydrates or your simple sugars, like your sweets, candies, cookies, pies, cakes, donuts. But that's all of us, right? Everyone needs to be careful of those things. So, when you don't let patients get too caught up in being worried about having to follow a special diet, because really they need a healthy diet like we all do. Sometimes they need weight loss, and sometimes making dietary changes can help with weight loss, which can help with that insulin resistance, which is how it kind of helps those type 2 diabetics. But diabetic patients still need carbohydrates just like anybody else. Remember, our carbs are sources of energy, fiber, vitamins, and minerals. There's no ideal amount for diabetics, so we can't say all diabetics should have this amount of carbs. No, it's going to depend on your height and weight, your goals. Do you need to lose weight? Do you need to gain weight? Are you active? Are you retired? These are all going to come into play. So really, diabetic patients need to work with their dietitian and their doctor to determine how many grams of carbohydrates they should have. Fats and proteins don't really impact the blood sugar, but they should still follow the dietary guidelines for Americans. Alcohol can be a problem for diabetic patients. Alcohol inhibits glucogenesis, that breakdown of glycogen to glucose by the liver. So patients who are on insulin can become hypoglycemic when drinking alcohol, or if they're on those oral agents such as metformin. So alcohol can fit into a plan with moderate use, like it should for all of us. Extra carbohydrates might need to be taken with alcoholic drinks just so you avoid that hypoglycemia. And really, diabetic patients should avoid like mixed drinks because those can tend to be sweet, those mixes, and it's hard to judge. It might be hard to judge how much alcohol is in them. It might be hard to judge how much sugar is in them. So those really should be avoided. So, oops, sorry about that. In the past, diabetic teaching used to be more restrictive. As most of you know, I was a dietitian before I was a nurse, and started a million years ago, and our diabetic teaching, was it was definitely more strict in the hospital. I remember that. Today's goals are really more about meeting the needs of the patient. We want to manage their disease. We want to reduce those complications, rather than just saying, oh, you can't have this, you can't have that. We want to help patients make uh, fit, their diet into their lifestyle, but making sure it's still healthy as well. So one thing they can do is carbohydrate counting. You probably, the hospital, most of the hospitals are doing this nowadays too, so you've probably seen this. The grams of carbohydrates needed are determined by the doctor and the dietitian based on patient's need, patient's lifestyle. You're going to take into account their blood glucose, their age, their weight, their activity level, any medications they're taking, etc. But typically, most adults are going to need 45 to 60 grams of carbs per meal. Each serving of a carbohydrates is about 15 grams, like a slice of bread, typical slice of bread. The amount of carbohydrates in a meal, it's going to need to correspond with how much insulin the patient's taking. So typically, 1 unit of insulin per 15 grams of carbs. But again, you're going to want your patient to work with the doctor and dietitian to determine how many carbohydrates is appropriate for them. But patients, this is part of education. Patients need to become familiar with how much carbohydrates is in servings of foods, being able to read labels properly. This is very important. Now, we could still use the exchange list to help diabetic patients with diet. This is what we used to do. And it's still used, and for some patients it can be very helpful if they want more of a specific plan to follow. It also can help with weight loss. This is where each per each group of foods, how much they can take, requires some weighing and measuring, but it is good. It is something that might be appropriate for some patients. You can also use the MyPlate, which we discussed in the nutrition lecture last semester, and page 1122 of your text talks about MyPlate if you want a review on that. So then, of course, we have the nursing process in diabetes, right? You're going to be utilizing that. Think about what you're going to want to know when you're doing your assessment. Obviously, we have our things that we need, our objective data, right? Our vital signs, lab values, your head-to-toe assessment, weight history. You're going to want to gather subjective data as well. So, how is the patient feeling? How are they managing their diet? What are they struggling with? Think about when you're doing your nursing process, think about your plan. What are your goals for the patient? Again, the goals of a younger person, a student, an athlete, somebody working is going to be different than an elderly person who's been diagnosed with type 2 diabetes. What are the goals? What has the doctor set? How are you going to help your patient? How can you help to prevent or minimize the complications? There's a lot of health promotion teaching with diabetes that's necessary. Not only the health promotion, but teaching your patient about acute and long-term complications so they understand. What other part, do we need to collaborate with anybody, other members of the team? Does the patient understand their medication regimen? Do they have supplies? There's a lot of teaching that needs to be done. And we talked a little bit about diabetes and exercise. Exercise is great for diabetics. It's really important, but patients should have, of course, doctor's permission to exercise. If someone has never exercised before, it's obviously going to be a little different than someone who's used to regular exercise. Exercise decreases insulin resistance. It can help lower blood sugar, so it's great. However, patients who take insulin or oral hypoglycemics can be at risk for hypoglycemia when exercising. So they should really exercise about an hour after a meal or take a 15-gram carbohydrate snack, and check their blood sugar before they exercise. They may need to take carbohydrates in 15-gram increments during periods of prolonged activity. So maybe if you're going on like a long hike for the day, and about every 30 minutes. And of course, somebody who is diabetic should always carry fast-acting form of glucose during exercise, just in case. And also, patients need to be aware that exercise-induced hypoglycemia can occur even several hours after the activity. So they should be aware of that. That is a possibility. So again, just management of diabetes. There's a lot to think about. There's a lot for your patients. Patients should know why they have diabetes, how that happened, what's happening in their body, teaching them about their activity, how to manage activity, nutrition, their medication, how to monitor, and how to reduce their risks. And follow-ups, routine follow-ups are really important for our diabetic patients. They may need regular visits to a dietitian for a while. They should have regular visits to their endocrinologist. They should have annual physical and annual eye exam, and there's self-foot care that we're going to talk about, and they need to have their feet examined, of course, by their provider, but we can't just do that annually. Diabetic patients need to do that every day, and we will talk about that shortly. So here's a great little chart you can take a look at, just looking at the differences between hyper, which is high, and hypo, which is low, glycemia. Look at the differences, the causes, the symptoms. So something you need to be aware of, and something that you are going to also teach your patient, because the patient needs to know this so that they can help manage their diabetes. So one of the complications of diabetes is diabetic ketoacidosis, or DKA. This is a complication. Patients with DKA, they're going to have hyperglycemia, ketosis, acidosis, and dehydration. It's a deficiency of insulin. Usually happens more in type 1 diabetics. Can happen in times of stress or illness, or this is what happens to people that don't know they're diabetic. It can happen from lack of knowledge of management, like somebody just not managing their diabetes or neglecting it. So what happens is, because of not having any insulin, the glucose is not used for energy. So because the glucose can't be used for energy, fat stores are broken down. So that's where you get the ketosis from. Protein synthesis is impaired. Then you get the nitrogen loss from the tissues. Insulin deficiency also stimulates the production of glucose from amino acids, which adds to the hyperglycemia. If untreated, there's going to be osmotic diuresis, so you're going to get that depletion of sodium, potassium, chloride, magnesium, phosphate. The patient might vomit from the acidosis, adding to fluid and electrolyte loss. They may go into renal failure, shock. It's a medical emergency. It can kill somebody. You'll see these are the patients that come into the hospital with blood sugars 800, 900, 1,000. And so it's a medical emergency. So this is one of the things you want to teach your patient on how to avoid. Oh, and one thing we didn't go over with DKA, one of the things that you will see and is specific to this is you get that fruity smelling breath. And it really does smell fruity. So that is, you might see that in a test question or an NCLEX question. That is always a DKA. So there's also hyperosmolar hyperglycemia syndrome, HHS. This is also life-threatening. It's also a medical emergency. So for these patients, you see this more in type 2, because these patients usually can make insulin, but they still, in the type 2s, remember we said it's not really very efficient. So, but they still can have issues with severe hyperglycemia, osmotic diuresis, and extracellular fluid depletion. More common in those over 60. Sometimes can happen because of a UTI, pneumonia, sepsis, or other illness, or undiagnosed type 2 diabetes. Again, this is also life-threatening. You still have that little bit of insulin, so you don't get the ketoacidosis, but you will get that higher glucose over 600. Sometimes it can resemble a stroke. So a lot of times that's what you might think, especially because of being an older patient, but it can actually be HHS. So here's just a great little table. You can kind of see the differences between those two complications. You can take a look at that. So the problem with diabetes, right? We have long-term complications, and these develop slowly, take a long time to develop, and are the result of poor control or undiagnosed diabetes, therefore poor control. So DKA, yeah, that and HHS, those are emergencies, but we also have these. These are the real killers, I think, in diabetes, because once they start to happen, you really can't reverse them. You've got the angiopathy, diabetic retinopathy, diabetic nephropathy, diabetic neuropathy, a lot of apathies, foot complications, skin problems, infection, and of course the psychosocial issues that go along. Right? So here's just another great chart, the chronic complications. And this is what is so important to impress upon your patients and to teach them about, because this is a lot. You don't, we don't want this to happen to people. So with good blood glucose control, we can prevent or delay these complications, or maybe they won't be as severe, because they do happen. And you may have seen that if you work in long-term care, you definitely have patients that might be missing a few toes, or we have patients that are missing limbs or have these issues with neuropathy from uncontrolled diabetes. So one of the complications we'll talk about is this disease of our blood vessels that can occur. Basically, this is damage to the blood vessels because of the chronic hyperglycemia. It's a leading cause of death from diabetes. About 68% of people that die from the effects of diabetes, 68% of it is from cardiovascular disease, 16% of it's from stroke. It's chronic. You've got macrovascular and microvascular. So with macro, obviously that means bigger. Those are the large and medium-sized blood vessels that occur. That's where you get that cerebral vascular or your cardiovascular disease. Micro is, those are the smaller capillaries and arterioles, which is where you get the damage to the kidneys, the eyes, and the skin. And again, these things take a long time to develop, 10 to 20 years after you're diagnosed with diabetes. So that's why, by the time it gets to be really bad, it's really, sadly, it's too late to reverse a lot of these long-term complications. Diabetic retinopathy, this is from that chronic hyperglycemia, and this is why it's very important for your diabetic patients to go to the eye doctor every year. They should get that annual eye exam. They should have the pupil dilation, which if you've ever had that, I know everybody hates it, but it's really important for diabetic patients to have that. Because the earliest and most treatable stages of diabetes-related retinopathy, they're not going to cause any change in your vision. You're not going to know. It's not going to prompt you to go to the eye doctor. So that's why you need to go every year to do this. Also, managing hypertension will also help with that. Then we have diabetic nephropathy, right? This is our damage to our kidneys. This is the leading cause of end-stage renal disease in the United States. If you work in dialysis or you work with a lot of renal patients, you'll see that pretty much all of them, almost all of them, have diabetes. Risk factors include hypertension, a genetic predisposition, smoking, and chronic hyperglycemia. Prevention, you want to do annual screenings to check, you see how your kidneys are doing. It's manage your blood pressure and manage your glucose. It's just, these are just so important, these long-term complications. You want to, kidneys, so important, eyes, so important, right? We want to help our patients and impress upon them that this can happen. Then you have diabetic neuropathy. This is the nerve damage still, mostly hands and feet bilaterally, includes a loss of sensation, abnormal sensations, pain, paresthesis. Pain's been described as burning, cramping, crushing, or tearing. These patients usually have a loss of sensitivity to the touch or temperature, so they could get injuries to their feet and they wouldn't even feel it. Why this happens, we really don't know. It's thought that because, thinking of that hyperglycemia, because of that, the accumulation of sorbitol and fructose in the nerves, because sorbitol and fructose are the products of glucose metabolism. So they're thinking that maybe because there's too much of those in the nerves, it can cause damage, but again, they still really don't know. You've got sensory neuropathy and autonomic neuropathy. These are two different kinds of neuropathies. So sensory neuropathy, this affects your peripheral nervous system. Kind of what we talked about. Again, treating this is good control of your blood sugar. Drug therapy, it can be treated with drug therapy, like, once it progresses to the fact, that it can't be reversed. These are the patients usually on gabapentin or Lyrica to try to help with this. And then there's autonomic neuropathy, and one of the most common things you see with this is the gastroparesis, and that's a delayed gastric emptying, and that can be a problem. So, if you could get hypoglycemia because you're delaying food absorption. Sexual dysfunction falls under here too, erectile dysfunction, also decreased libido, vaginal infections such as candidiasis. Also, part of this neuropathy is neurogenic bladder or urinary retention that can happen just from this, the damage to the to these areas. So foot complications, right? Most people are familiar with this. If you're diabetic, you need to be careful of your feet. It's really important that a diabetic patient checks their feet every single day. If they don't have someone at home that can help them check the bottom of their feet, they could use a mirror, and they should avoid injury, avoid going barefoot because they wouldn't feel something. Skin and nail care is important. Proper footwear, wearing shoes that fit properly, and if they have any develop any wounds or ulcers, that they contact their doctor right away to get proper treatment, because if you lose that sensation, you're not going to be able to feel something that's there. And also, diabetic patients have slower wound healing, so that's also an issue. So infection and diabetes, this is also something that your diabetic patient needs to be aware of. Diabetics are at risk for recurrent or persistent infections. Sometimes that's how people find out they're diabetic, is because they've got an infection that just won't resolve. They should be treated promptly. You can educate your patient on proper hand hygiene to try to prevent spreading germs, avoiding exposure to people with illness, how to prevent urinary tract infections. We talked about that last semester. That's something else you can teach them about. Just because diabetic patients, it just takes them a little bit. It's just a little bit harder to heal from infection. So the best thing to do is to prevent it altogether, right? And then there's the psychological considerations of diabetes, because it's a lifestyle change. Think about it. If you're the patient and you've just been told that you have diabetes and now you've got to do this, manage your condition for the rest of your life. Oh, and if you don't, look at all these terrible things that can happen to you. So it's, it's a high rate of depression with patients that are diabetic, anxiety, even eating disorders. Eating disorders can happen, especially in the adolescent female population, just because of the strict focus on food intake. So you can get a little crazy. So, you might want to point your patients towards, support groups or other things online that they can find, just to help them find new recipes and connect with people that are also having the same experiencing the same thing. So that's all I have for the diabetes voiceover. There's another voiceover on Blackboard on the medications. That was done by another instructor from a while ago, but she did a great job. So I left that up for you guys. I think it'll be very helpful. And I look forward to seeing you in lecture.